Hi, this is Elliot Fishman, and this is You Make the Call. And since we have one of these cases every week, this will cover a lot of ground. Also, we are putting together on the website a special section that has all the You Make the Calls, which are one of the most popular sections we have. So with that, let's get started. What about this case? Cystic lesion, tail of pancreas, nodularity. Could it be an MCN? Yes. Could it be a IPMN with malignant transformation? The answer is yes. Serous cystadenoma is a possibility, but the wall is kind of thick for serous cystadenoma. What you really need to also think about, and we talk about this, is neuroendocrine tumors. Neuroendocrine tumors typically are hypervascular. They can be small, they can be large, but we do see cystic neuroendocrine tumors. The thing is, when you see cystic neuroendocrine tumors, typically the small ones are cystic with rim-like enhancement. This has some rim enhancement and nodularity, so it would be really atypical. But again, when you have to answer the question, you got to really think about a cystic neuroendocrine tumor. I'm not saying it's the only diagnosis. I gave you a few others. I might have gone with an MCN in this case if I had to pick one thing. But cystic neuroendocrine tumors, beautifully shown here on the volume rendering, that rim enhancement is just so nicely shown. Here it is on the cinematic as well. So when you start getting cystic lesions, even when they're a bit larger, they have nodularity, wall enhancement, and usually the enhancement is 360. You got to be thinking about neuroendocrine tumors. In this case, we see a 1.5 centimeter nodule to the left of midline. It looks like a node. When I think about it, I would say a node. I could also think about a thymoma. Doesn't look like a teratoma, doesn't look like lymphoma. If I told you the patient was hyperparathyroid, then you would think differently, of course. And that was the situation here, and this was an ectopic parathyroid adenoma. What's unusual, however, is it's not vascular. Most of the times, ectopic parathyroid adenomas are very vascular. Also, they're typically located beneath the thyroid or more forward in the anterior mediastinum. This was a very unusual case, and the history led to them working it up correctly. Just a really nice example. You see it on the coronal views very nicely on the 3D. And just to show you another example where, again, a tiny nodule, anterior mediastinum, was also an ectopic parathyroid adenoma. Just a really, really nice example. This patient presented with neck pain, and you see swelling in the right side of the neck. It could be nodes, it could be inflammatory. What you don't have here is a venous phase imaging, and I want to make the point that I need a venous phase because I want to know what the jugular vein is doing. When I get a venous phase, you see the jugular vein is thrombosed. Okay, jugular vein thrombosis can be due to infection. It can be due to tumor tracking down the vein or tracking up the vein. It also can be iatrogenic, patients who've had lines in place. So those are all things you need to think about. Get a little more history. This was jugular vein thrombosis due to catheter placement with local inflammation. Again, be very careful. If you don't see the vein, it may be occluded or you may be just too early. So make sure you have a good venous phase, and very nicely here, you see the jugular vein thrombosis. You see the inflammation. When I look at the cinematic rendering, look how nicely the jugular vein thrombosis is seen. You can see the length of it. You can see the catheter tracking down. And it really is that the catheter caused the jugular vein thrombosis. People typically say that the longer the catheter is in, the more likely you can get JVT, but you could have it only in for hours and still get the complication, though that's less common. This patient presents with fever and IV drug abuse. Well, we're looking at multiple cavitary lesions. Yes, you can get metastatic disease that cavitates, but these are mainly in the periphery of the lung When I see cavitation, when I see wedge-shaped lesions, when I see periphery for the most part, I'm always thinking about septic emboli. Septic emboli can be due to many causes. IV drug use is probably one of the most common, and the history here made it, I think, very easy for you to get the right diagnosis of a patient having septic emboli due to IV drug use. The patient also had endocarditis, which is all common things that go together. Here are a few more images showing you some of the mediastinal adenopathy in this patient, showing you very nicely the multiple septic emboli that are present. So just a really nice example of what we're dealing with. This patient has right upper quadrant pain. Large mass in the liver. Could be hepatoma, could be necrotic metastasis, could be fibromyalgia, but usually it's not so cystic. Could it be an abscess? I guess so, but the periphery of the lesion is very sharp. Abscesses can be sharp sometimes, but there's usually perfusion changes. I tend to like a primary tumor of the liver. If I was pushed beyond hepatoma, beyond cholangio, beyond metastasis, I would think of some sarcoma. Angiosarcomas are usually vascular. This ended being a fibrosarcoma. That's pretty unusual. Large, enhancing, necrotic tumor. Hepatoma to me is the best thought, but sarcomas do occur, and this was a great example of a fibrosarcoma of the liver. I think I've seen like 2 of these cases. Left upper quadrant pain. This fluid in the abdomen, the spleen is enlarged, and there's high density in the spleen. So it looks like maybe the patient bled, maybe the patient had infarcts in the spleen, maybe the patient had trauma. You would also want to know other history because it could be a sequestration. Could it be infiltration by tumor and that bled? Those are all things you're going to need to think about, and history is going to be very helpful. And in fact, in this case, it was a patient with myelodysplastic syndrome where they typically get very large spleens, and then the patient developed upon spontaneous splenic bleed, shown nicely there. Here it is with some delayed phase imaging showing you the compression of the splenic tissue with the bleed present. Just a very nice example of this case. Just really impressive. Here's a patient with pelvic pain. When I look at this, the first thing I think about, male or female, it's female. Could this be ovarian cancer, carcinomatosis? You go through all those possibilities, and I'm focusing on malignancy. But we've shown in conference, we've written articles that you need to be thinking about one other thing. At times, endometriosis, particularly if the patient is younger, but endometriosis occurs in the 40s, even 50s, can look just like ovarian carcinomatosis. It can have small cystic lesions, big cystic lesions, implants on ureter, implants on bowel, implants on the liver. And guess what? This was endometriosis. Just a really nice case. Here's some more images down into the pelvis, and you could see I would be thinking about ovarian cancer, ovarian masses, but you can be fooled. This was a really nice example of endometriosis, a really nicely challenging case. In this patient, we see a mass in the abdominal wall that's enhancing. Most commonly, I would be thinking about a desmoid tumor. I don't see much else going on, but this wasn't a desmoid tumor. So what other tumors? Metastasis from renal cell, metastasis from melanoma, lymphoma are all possibilities. And that's what I'd be favoring. But, you know, every once in a while you get fooled. This was a patient with endometriosis. Now, patients with endometriosis can have implants in the abdominal wall, typically at surgical sites, particularly in patients who've had C-sections or in patients who've had appendectomies. But this is much higher up, right? This is upper abdomen. Just a really nice example, very unusual example of endometriosis. What a great case. Endometriosis, you can see here some more images, and you can see there is a mass also in the abdominal wall in the right lower quadrant. I find endometriosis to be extremely challenging because it's a wonderful mimicker. It's a great case at conference, but you always need to at least think about it, particularly in difficult cases. This patient has abdominal pain, and you can see the stomach is distended. Then there's a large mass in the region of the antrum. Could be lymphoma, could be a GIST tumor. It looks like it's malignant, right? There's no doubt about it. It doesn't look like it's a bezoar because it's too solid. Now, there are other things that occur. Again, lymphoma, adenocarcinoma, GIST are the best ones. This was resected. It was a gastric juvenile polyp without malignancy. Juvenile polyps are usually small. We talk about polyposis syndromes. What a great case. I don't think I would make that call in a million years because to me, it's an older patient, it's obstruction. I probably would have gone with GIST, but look at the size of that mass. Wonderful, wonderful case. Chest pain. Well, there's a large mass in the right lower lung which is extending directly through the pulmonary venous system into the patient's atrium. So you have a tumor in the left atrium. It's not a myxoma, which we typically think about tumors. It's something that invades in. And the things that invade in can be lung cancer, can be melanoma, and can be sarcomas. So I'd be going with those as the possibilities. And this indeed was melanoma growing into the left atrium. Large masses, sarcomas, melanomas, as we discussed, can grow directly into the atrium. It's a really impressive appearance. It's not that common, but it does occur, very nicely shown in this example. And that's it. Those are our latest and greatest set of cases. You make the call. Again, 2 images, think about it, differential. It's not always the final answer that matters. It's how you think about it and how you manage to work up the patient. And with that, I thank you for your attention. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.